This video demonstrates the arthroscopic excision of the dorsal wrist ganglion. Ganglions are fluid-filled sac arising from the wrist. Dorsal ganglions arise from the radiocarpal joints or from the midcarpal joints. They are usually painless, fluid-filled sac, and excision is warranted only after a trial of conservative treatment has failed. This cyst arising from the radiocarpal joints between the EPL and the ADC. MRI is indicated only when you're planning for arthroscopic excision, or generally it is a clinical diagnosis which helps us to locate the pedicle of the cyst and excise it arthroscopically. Here it is arising from the radiocarpal joints near the scapholunate junction. Typically dry arthroscopy is done, and these are the setup. 1-2 portal and the 6R portal are the most commonly used portals. They can be used interchangeably as a working portal and the visualization portal. This is a 1-2 portal, which I'm going to use it for the visualization. I usually prefer a dry arthroscope initially, only when inaccessible, and if there is need for joint distension, then we use fluid. We are visualizing from the 1-2 portal. You can see the asterisk there. That's a faint bluish cyst seen on the dorsal capsular reflection. That's the lunate there, and you're seeing the ulnar corner. Now we are making the 6R portal. The normal saline is used to distend the joint. Now we can see the cyst better, and there's a lot of synovitis as well on the dorsal capsule, which is shaved off. A small shaver joint is preferred for these procedures. And now as soon as we go near the cyst, the pedicle is shaved off, and this is visualized as a change in the consistency of the fluid, which is seen as floaters or some turbulence in the fluid there. Or else this is much better visualized if we are doing a dry arthroscope. All the synovium is debrided, and a 2 mm of capsule is also excised through the shaver. This clears the cyst and the capsule adjoining capsule, and you can see the tendon which are moving. These are the ADC of the index, middle finger, which are moving because of the transmitted movements which I am doing outside. This is the depression after excision, which you can see, and these are the movements. There's hardly any scar, which can be closed, or you can do a subcuticular closure.